Ladies and gentlemen, I will turn your attention to the interventional radiology point of view of the treatment of this. And here are my disclosures. My co-worker or co-author is the obstetrician. So here are my learning objectives, and I will start on the clinical evaluation of postpartum hemorrhage, already been mentioned many times here. I just repeat that 18% of deliveries that got blood loss more than 500 milliliters, 5% 1,000 milliliters, and 15, some authors present higher numbers. 15% of all maternal deaths are due to hemorrhagic shock. Definitely, the postpartum hemorrhage is the most frequent cause of death in my country. As you heard, that's divided in early, primary hemorrhage up to 24 hours. Majority of that are uterine atony. And there is a rule of 4 T's. If you look at that's tone, tissue, it means retained placental fragments, genital laceration, trauma, and coagulation disorder, thrombin, so 4 T's. And what's important for the radiology is that the genital laceration is important and coagulation disorders. So we have to pay attention to these two issues. Delayed hemorrhage starts after 24 hours due to infection, retained products of conception, and vascular abnormalities, especially pseudoaneurysms. These are, if the delivery was done by cesarean section, that level of a lower uterine segment in anterior part, but if it is a regular delivery, then these pseudoaneurysms could be in a variation of locations. Their incidence is around 3%. So first, as you heard, that diagnosis and proper recognition is saving life. Then the treatment includes the fluid resuscitation, balloon tamponade, compression sutures, B-Lynch sutures, arterial ligations. Here is the anatomy of the hypogastric artery, and this is the uterine artery, this is the vaginal branch, and here is the anastomosis to the ovarian artery. And the sutures by surgeon are placed at certain steps, and in majority of postpartum hemorrhages, this is the first-line therapy, since it's done by obstetrician. Here is the patient who had postpartum hemorrhage, and the obstetrician performed ligation of hypogastric artery. This is maybe Professor Gupta note that better, that at this level is the ureter, which should not be injured. And if you see that this is the angiogram, since the bleeding did not stop, there are the horizontal and vertical anastomosis, so the feeling of that the vessel behind ligation is immediately, but the flow is not pulsatile, and therefore the bleeding, therefore it works. As a last resort is a total abdominal hysterectomy. The history started in 1979, already been said here as well. So now I will speak a little bit about the anatomy, arterial anatomy. So the hypogastric artery has got its posterior division, which is called parietal, and anterior division called visceral. And the anterior division is our goal for catheterization and embolization. We started usually the flush pelvic aortogram, and for us it's very important the origin of superior gluteal artery, since we want to spare or to save the patency of this artery to avoid buttock claudications. So in this particular case, that's the superior gluteal artery, inferior gluteal artery, so embolization of those should be avoided. And this is another variability here, since the inferior gluteal artery arises from the superior, so that's some gluteal artery bifurcation. If you look at this angiogram, I mean, majority of you are radiologists, that's a question, what kind of this artery is it that looks like an inferior gluteal artery. And this is quite rare anomaly, and we should diagnose that before we embolize hypogastric artery. Otherwise, we would embolize the lower extremity and cause the severe ischemia of that left leg. The uterine artery can be recognized easily on angiogram according to its U shape. So it's got the descending and ascending part. And there is also variability of origin of this artery. And in majority of cases, there are two main divisions of hypogastric artery, and I would say in 60%. And in 20%, we can observe actually three main stem, and in some cases, the multiple origins of all these arteries. The ovarian arteries, already been demonstrated here as well, can be seen on the aortogram, which is done a little bit from the above, from the level of renal arteries, so we have to inject a little bit higher. And these could be hypertrophied, and they are very important collateral way. They are tortuous, and what's important if you embolize them, since there is a high flow in the abdominal aorta, and this artery is little, and that could be the reflux of embolic agent into the aorta, which can be overlooked and can cause, again, the peripheral embolization into the lower limb arteries. Also, that's the uterine ovarian anastomosis, and has been studied for uterine artery embolizations, uterine fibroid embolizations. And if there is a flow from the uterine artery towards the ovarian artery, you can, if you do embolization, you can do the ischemia, you can cause the ischemia of ovarium, and then the subsequent amenorrhea. So these two anastomosis, type 1B and 3, seems to be danger. Pudendal artery is another artery which is included in this topic, and usually this is done then on a regular delivery, which in this particular case was complicated by perivaginal hematoma, and there was a revision, hematoma aspiration, and we did the angiogram and seeing the pudendal artery laceration at this level here, and we did the embolization and stopped the bleeding in this particular case. So again, the pudendal artery belongs to the parietal branches of the pelvis. There is also the variation in origin of the pudendal arteries. Sometimes they can originate from the supragluteal artery. So, how to understand the catechization and embolization techniques? So, from beginning, we place the hook catheter across the bifurcation, and then we prefer Robert's uterine catheter, which is it has to be reshaped, and it's got one very long curved segment, and using this easily you can reach bilateral hypogastric arteries and even selectively uterine arteries. For embolization and for origin of the uterine artery, the AP view is not the best one. And so we have to do some oblique views to find the origin of uterine artery, which is before embolization, which is after embolization. It's said that for multiple branches, as one of the variations, then the ipsilateral anterior oblique is better, but if the uterine artery arises from the anterior part, then contralateral anterior oblique is better, but depending on your technique. Bilateral embolization is necessary. So if you don't see extravasation on one side, do both bilateral embolization of the uterine artery. This is how we do that. That's done pieces of gel foam, gelatin sponge, or we can create with a mixture with the iodinated contrast medium and with the passage through the freeway stopcock, the foam, which can be easily injected through the 5-French catheter. And this primigravida had hemorrhagic shock after abortion with uterine revision, second day continuous metrorrhagia, second revision including the abdominal cavity, suture of the perforated uterus, and hemoperitoneum. So pretty complex patient. This is the AP view, and this is the uterine catheter, which is placed with its tip in the descending part of uterine artery to achieve free flow embolization. You mean that you should not cause the vasospasm to inject the embolic agent down to this branch, and this is an extravasation seen on the flush angiogram before. So again, the catheter should be in this descending part of the uterine artery, and this is after embolization. This is a young woman with spontaneous abortion. She had revision of uterine cavity. 1 month later, she suffered from metrorrhagia, and she had second revision, and MR revealed this hypovascularized tumorous mass and uterine fundus. And this was the arteriovenous malformation, which was the cause of bleeding. And in this particular case, they use the coaxial technique, the microcatheter, and this microcatheter was because this is a large artery, which is hypertrophied, and you see here AV shunting, malformated arteries, and the microcatheter, and this is an indication clearly for glue and butyl 2-cyanocaride. So here you see the filling and penetration of the glue as Dr. Pallerini showed you. This is how we mix it in 1 cc syringe. This is the lipiodol, which is the acrylic glue, and mix it like this and inject. This is another case with retained abortion, 18 weeks, uterine laceration, hypovolemia, hemoperitoneum, revision of uterine cavity, second day, revision of uterine and abdominal cavities, resection of right ovary, and referred finally to angiosuite. So that's uterine artery, and this is the cervical branch, and this was clearly iatrogenic injury since this was just revision due to abortion. Again, before and after embolization. And finally, sometimes we face this situation, that's the second para with regular delivery, uterine atony. She had a revision of uterine cavity and second and transabdominal hysterectomy for bleeding, left-sided endexectomy, another revision, and so on and so on. So, but if you look in the angiogram, there is severe spasms of arteries, external iliac arteries. This patient was clearly in hemorrhagic shock. So sometimes to navigate the catheter in these settings is very, very difficult. We proved the extravasation in up to 50%. And there's an issue which will be probably discussed in the end is how to minimize radiation exposure. So, I mean, these are generally known rules, but what's the most important to minimize number of DSA runs, reduce pulse rate, code down, which is seen here, and so on. Fluoroscopy, we have a high-quality fluoroscopy, so it's enough, and the reduction of dose during recording the angiograms, it's tremendous, so don't use DSA runs. Radiation dose in our old practice, that the effective dose ranged from 4 to 35 millisieverts, and in average was around 16 millisieverts, which corresponds to the, in average, to 6 years of natural background radiation in Czechia. So that's the radiation dose which we gave the patient before. And last issue I like to address is results of embolization. Already been shown here that the primary success rates from 90 to 96%. And what are the causes of failure? Independent factors. I mean, more severely bled patients. That's hemodynamic instability, lower hemoglobin, coagulopathy and proof of extravasation. But in this particular study, they revealed also the coagulopathy, but also collateral network and primiparity to be an independent factor for postpartum hemorrhage. What are the complications? They can be divided into hypovolemia-related, embolization-related, transfusion-related, and fertility. I will speak about only the embolization-related, which you heard that about 4% can occur. Usually they are due to collateral ischemia, which is caused by unwanted embolization. And fertility, it's in relationship to amenorrhea. So fertility, that was studied in these two studies, and what's already been mentioned here too, that in this study they revealed that in all 4 deliveries, the postpartum hemorrhage repeated, which is alarming. And in the same team published the 21 pregnancies, and they didn't see that after ligation of hypogastric arteries. So ligation against the embolization do a different way regarding this complication. So what are the rules? Known or appreciated risk of postpartum hemorrhage, then the delivery should be done electively in the daytime and with pre-arranged IR support. Second, bilateral ligation of uterine arteries often fails if bleeding originates from the lower uterine segment or cervix. I don't know if you can recognize it clinically without angiography. Bilateral embolization should be preferred if there's a late referral, massive blood transfusion, and clotting abnormalities. And finally, hysterectomy is indicated if there is a persistent hemorrhage or hemodynamic instability 1 hour after embolization. Earlier recognition prevents death, already been said here. Genital tract laceration, the worst prognosis among those patients. Embolization should be preferred over ligation and can occur, as you heard, after hysterectomy, especially in disseminated intravascular coagulopathy. Intractable or continual hemorrhage after surgery. If you do embolization, look around. It means to lumbar artery, sacral artery, and even the branches of external iliac artery. So all these arteries can be the origin of the hemorrhage and being injured during the delivery or surgery. Why there is a low utilization of embolization for postpartum hemorrhage? Since there is a limited number of angiography units and skilled 24/7 on-call teams. And also there is a significant risk of patient transfer if he or if she is in unstable condition. If you look in my area, in the Czech Republic, so in our center we had 2,300 deliveries per year. In the same area there are 3 other hospitals having 2,700 deliveries per year. So I mean, the direct access to this to embolization, it's not guaranteed in these hospitals. And moreover, if you have expected complicated deliveries, they send these women to us because we cover a larger area as a perinatology center. So here are my conclusions. And early recognition prevents death. Bilateral embolization of the anterior division of the hypogastric artery should be first-line therapy if interventional radiology is available. Prefer it if there is a late referral, coagulopathy, and lower uterine segment hemorrhage. The interventional radiology should be aware of the way of delivery, since, I mean, as I said, that if it is a cesarean section or vaginal delivery, that the origin of the bleeding could be from the different branches. Should know about the previous surgery and ligations, and of course look for coagulopathy. And embolization preserves fertility. However, there is certain risk of repeated postpartum hemorrhage. So be careful, already been discussed here. So thank you for your attention.